I'm Dr. Vanessa Johnson. I'm the Medical Director of Palliative Care here at ECHO. I am also a regular general hematologist oncologist. I specialize in breast cancer, so that's my other hat here. And I also am the Director of Hospice. But we really wanted to talk about the Palliative Care program because that's a new thing that we started in May of this year. Palliative care is something that people don't understand very well. It's a new field. It actually was a brand new field as of 2006. Medicine is any of you who have been in the system know, it's very fast-paced. Appointments are not very long. It's very complicated. We oftentimes don't have a lot of time to spend looking at the big picture of what's happening with a patient. And as patients get more complicated diagnoses and have more complicated symptoms and therefore have more complicated needs, these things sometimes fall through the cracks and are difficult to kind of get your arms around. So that's where palliative care kind of initially came out of, is a need to have more wraparound care and more holistic care for patients that are struggling with really serious, potentially life-ending illnesses or just very complex medical situations that require a lot of coordination and a lot of care. We try to assess the patient's depth of understanding of what they're facing and really fill in any gaps or things that are unclear and get a good sense of what the person has, what they're facing, what the options are, what the expectations should be with therapy and longevity and quality of life issues. And then we go over symptom management, really any symptoms that are an issue that are interfering with someone's quality of life, and see if we can have additional input therapies, other physician referrals, things that we can do. We work with physical therapy for that. The other thing we address is financial issues, which is something that is not oftentimes addressed. Physicians aren't really geared towards that, understandably so, but limits in finances, effects on employment, struggles with getting rides, with paying bills, with just preparing for what's coming and whatnot can be a major issue for patients. We also try to touch base with the patient's support system to make sure that they're okay. Caregivers are a big part of this, and supporting the caregiver can be just as important as supporting the patient, and to understand what their needs are and see if we can help with that. One of the other kind of overarching goals of palliative care is to not have it, to not have things that come up become a crisis if we can avoid them. Because if we knew about them in advance and we took care of them, and maybe we didn't need to do it right that minute, but it's done, and then if someone gets sick later down the road, things are already in place. We really want to try to make things smooth and as comfortable, keep people as functional, and really be able to do the things that they want to do as much as possible in the setting of dealing with a major medical illness. Palliative care is a team. You can't do palliative care without a team approach. We have up to about 10 people just in the practice alone that are involved with the palliative care program.
Some of my core responsibilities with the palliative care team are to work with the clinical team to change their treatment plans as far as chemotherapy regimens and going forward with supportive care or hospice care versus full treatment. Any changes that are needed going forward for home care, social work, anything in the community that we need to set up, I send over referrals and follow up and make sure that everyone's taken care of. Our focus here for the palliative care team is to focus on the family, focus on the patient, focus on friends, support systems, and make sure that everyone and everything is taken care of for them outside of the clinical aspect.
So I do an array of a lot of different services, a lot of different ways to support both patients and families, because this is not affecting just you, it's also affecting your families in some contexts. I can do as much as helping on a financial piece, helping you apply for Medicaid, giving you references on where to get assistance in the community, including senior centers. I can also set up transportation if you're having issues with obtaining food in the community. I can definitely assist with that. I do a lot of community resourcing, so I'm very in tune to what's available both to patients and families. So if you do need that assistance, please never hesitate to reach out to me. That's what I'm here for. I'm also here to provide emotional and mental support. So a lot of times when people are going through a new diagnosis or a diagnosis that you've had for quite some time, sometimes it really starts to affect our well-being, and it affects our families. Our families, are having a hard time understanding what's going on.
My role as the palliative care scheduler is to assist in scheduling the patients for the consultations with the physician and the providers on the team, and then following through with all of the recommendations and the referrals that need to be made to make sure that the system is navigated as seamlessly as possible for the patient. We refer out for the durable medical equipment, so hospital beds, wheelchairs, commodes. We refer out for meal services, Meals on Wheels, transportation services, whether it's to the senior center or a rideshare company. We refer out for hospice itself. We refer out for physical therapy, occupational therapy. We do all of it.
What makes our program unique is that most palliative care programs are actually hospital-based, and outpatient palliative care programs, particularly in a subspecialty office, are pretty rare. So that's part of what we're trying to bring. When the patient comes in for their first consultation, it's a 90-minute consultation, which is kind of fabulous. We don't usually get that kind of time with patients, and so that is perhaps one of the best things, is we have time to really sit and relax and talk in depth and at length about what's going on for that patient, and answer questions and clarifications, and really delve into some of these other issues that are far beyond just the here's your treatment, here's your plan. There's oftentimes things that need follow-up, so there can be follow-up with the social worker for emotional, financial, other arrangements that need to be made. We make referrals as needed from there to physical therapy, or to integrative medicine, or to behavioral health, or any other resources, and try to follow up and make sure those referrals have happened. We will usually have a follow-up appointment with a member of the palliative care team, either myself or one of the nurse practitioners. Depending on what's happening with the patient. Sometimes that's as soon as a phone call the following week to see if adjustments to pain medication have helped. Or it could be someone that we don't see for another 2-3 months because they're kind of going along with their therapy and things really look pretty stable. And again, this is over and above and in addition to what the regular oncology care is that's happening in the office, and in no way interferes with that. It's not something to be afraid of, palliative care. It's actually supportive and useful, and most people come out of a conversation about their bigger picture with far more understanding and hope and a feeling of being heard and being supported. We want people not to be afraid of it and use it as an additional resource for their cancer, or serious illness journey, and to look at it as an addition to it, a positive one, not as a something to avoid. It really isn't a scary thing, I promise.